Hi everyone, my name's Chris. My PhD aims to develop a nurse-led intervention for people with life-limiting multimorbidity. So definitions first. Multimorbidity, we mean two or more chronic conditions co-occurring in the same person at the same time. When we say life-limiting, we mean it would be reasonable to expect that this person will die prematurely from those conditions. So if you have one chronic disease, then your treatment will be based on evidence largely from randomised controlled trials, which is great. RCTs are the gold standard of experimental study design if you want to test if an intervention or a drug works well for one condition. If you have more than one condition, then there's a slight problem, because if you, for example, have heart failure and diabetes, you can't potentially not take part in a diabetes trial, because your heart failure might mean that the results might be skewed for that, and that's fine. We understand the reasons for that. The problem then arises that we have treatment regimes rolled out for particular conditions that are being used with lots and lots of people who don't always just have that one condition. If, say, for example, you have 4 conditions, you might have 4 different lots of drugs, 4 different lots of treatments, 4 different specialists. And if you're the kind of patients that I'm looking at, if you're in the last year of your life, this potentially isn't the best standard of care that you should potentially get. So there has to be some sort of generalist clinician looking over all the top of this and actually helping to organise care and make sure that it's optimal and it's actually the best thing for that person. And we propose that that person should be a highly skilled and highly trained advanced nurse. The reason why we think it should be a nurse, apart from the fact I'm also a nurse and obviously biased, is the fact that nurses are taught from day one to adopt a person-centred and holistic approach to the way that care is delivered. That simply means that we will treat patients in a way that takes their own individual situation and needs into account when we're planning the way that their care will be delivered. We're going to design an intervention around this. We will review the literature to see what is known already, see if there's things that we can take and incorporate into our own intervention. We're going to actually follow groups of patients around. We're going to go to appointments with them, we're going to get on the bus with them, we're going to interview them and find out what their experience is like and what the burden of care that they actually go through managing all of these conditions. We're also going to look at case notes to see why these people are ending up in emergency departments, for example, to see if that's something that we can avoid, or to see if potentially that's something that we could maybe identify patients who are at risk of not receiving the highest possible standard of care. The end result of this, the impact, what we're going to actually do is develop and pilot an intervention for a small group of patients and actually see how it works using an experimental design. I think that's something that's really important in healthcare moving forward. I hope everybody else agrees with me, and thank you very much for listening to